Let's try to clarify this case. Okay, so we have an individual with a bilateral open femoral fractures, both sides involved, and this patient remained immobilized in bed for 2 weeks. Okay, 2 weeks. Prolonged immobilization is a classic trigger of hypercoagulability and venous stasis, and both are two key components of varicose triad, as you know. Hypercoagulability and stasis, main or major components of the varicose triad, more related to venous problems. Remember that vessel wall injury, especially atherosclerosis, is more related with arterial problems. Okay? As a result, the patient developed a deep venous thrombosis, as we can see here during the development. Okay? And probably in the femoral veins because of the fractures. At some point, the thrombus detached and traveled through the venous circulation, ascending via iliac veins, inferior vena cava, right atrium, reaching the right atrium, passing through the right ventricle, and then entering into the pulmonary circulation via pulmonary arteries, where the embolus was arrested as a massive pulmonary thromboembolus. Because the patient died suddenly, an autopsy revealed a large bilateral hemorrhagic pulmonary infarct, the embolus must have been large, including causing obstruction of a substantial portion of the pulmonary arterial circulation, typically more than 60%, leading to acute right heart failure and sudden death. This explains why the correct answer is pulmonary thromboembolism arising from the femoral vein. Again, the venous thrombosis, the embolus detached from the main thrombus and starts to progress, ascending via iliac vein, inferior vena cava, and reaching the heart in the right atrium, passing to the right ventricle and moving to the pulmonary artery, obstructing more than 60%, probably a saddle embolism, causing sudden death, okay, because of acute right heart failure. The other options are or were incorrect in the question for timing and pathophysiology reasons. Let's see, an air embolism occurs abruptly and typically associated with medical procedures, trauma involving large veins, or pressure changes such as diving or aviation or working underground in a tunnel or something like this, not 2 weeks after immobilization. Bone marrow embolism and fat embolism can occur after long bone fractures, yes, but they characteristically appear early, usually within 24 to 72 hours, 1 to 3 days, not weeks later, as in this case. And a thrombus arising from the femoral artery cannot reach the lungs because arterial emboli travel away from the heart, not toward the pulmonary circulation. Again, a thrombus arising from a femoral artery or from any artery cannot reach the lungs because they travel away from the heart, not toward the pulmonary circulation. Okay? Now, regarding the other question, can this patient develop a cerebral infarct within 2 weeks? Yes, it is possible. Remember, prolonged immobilization alters Virchow's triad and creates a prothrombotic state. While most ischemic strokes are arterial in origin, systemic hypercoagulability can increase the overall risk of thrombotic events. Additionally, there is an important special mechanism to consider. A patient may have an undiagnosed intracardiac shunt, such as a patent foramen valve or an interatrial communication, and be completely asymptomatic. In that situation, a venous thrombus can bypass the pulmonary circulation and enter the arterial system. This makes a cerebral infarct possible even when the clot originated in the venous system. Therefore, the correct answer for the question 2 was true. Okay? Regarding the question 3, the key mechanism for deep venous thrombosis and brain infarct. Take a look to the question. They're not asking about deep venous thrombosis and pulmonary embolism. They are asking about deep venous thrombosis and brain infarct. And the key mechanism is a paradoxical embolism. Normally, venous thrombi travel to the lungs and cause pulmonary embolism. However, if a right to left intracardial shunt is present, such as a patent foramen valve, a thrombus can cross from the right atrium to the left atrium, bypass the lungs, and enter the systemic arterial circulation. And from there, it can travel to the cerebral arteries and cause an ischemic stroke. Now, important, without a right to left shunt, a venous thrombus cannot cause a cerebral infarct. This is why paradoxical embolism is the only valid explanation for a cerebral infarct originating from a deep venous thrombosis. Okay, so after this brief explanation, I have 5 take-home messages for you. First one, immobilization leads to hypercoagulability, and hypercoagulability increases the risk of deep venous thrombosis. Second, deep venous thrombosis can produce pulmonary embolism via venous circulation usually. Third, sudden death and hemorrhagic lung infarcts are findings in massive pulmonary embolism. Fourth, venous clots can lead to brain infarct only via paradoxical embolism. And fifth, timing matters. Fat and marrow emboli are early. Meanwhile, thromboembolism is late. Thank you.